First of all, I want to start by thanking the Foundation and the NPO for support. It's allowed us to really try something that I don't think anyone has tried before, and so it was a risk, and I think we've developed some interesting information based on that risk, and we hope to take it forward. The other thing I want to thank you for is letting us know very early that there wouldn't be a no-cost extension. So we could start planning from about month 3 for a no-grant extension, which Kathleen is going to come on and talk a little bit about at the end. So let me just, for the folks who haven't been here before, let me just remind you really quick what we're about. The aims were to see if we could really identify the workarounds and the small troubles that arise in daily nursing practice. A lot of that initial work from Anita Tucker and her direct observational studies of frontline nurses. And see if by changing the way that it's normative for the nurses to respond, we can change the culture from a culture that accepts workarounds and as a daily part of practice to a culture that seeks to implement systemic solutions to the problems that come up instead of doing workarounds. And that besides changing the culture of quality and safety, that it would also improve the quality of nursing work itself. The inefficiencies, the lost time away from the bedside during shifts that are spent doing the same workarounds day after day and month after month. We used a model as a nursing unit as a complex adaptive system where it's about the interactions and seeing what's important as opposed to necessarily just the individual agents or nurses or workers. We did a multiple prospective case study design, so we were at 2 hospitals, 3 intervention units and 3 control units at one hospital, 2 intervention units, 2 control units at the other hospital. And there was a mixed methods evaluation, a combination of both qualitative and quantitative. So here's this is the logic model we used in the proposal, and we're going to actually come back to it and use it today. And as a way of talking about what happened, I just kind of want to walk through the logic model and say what we expected and what actually happened. So the inputs are, that we have the nursing staff, the CNOs, the people in the middle, the nurse managers, the other people who work on the units besides the nurses, the clerks, and then obviously the physicians and the pharmacists and the other folks who are all part of that complex adaptive system in the hospital. The other input was dedicated meeting time to doing these quality improvements, and something Mary Naylor said is that there are so many things to fix that we all have in common in healthcare, and one of the things that we have to fix throughout the enterprise, the endeavor, is to know how to kind of fix the plane at the same time that we're flying it. And just as in aviation, it's very hard in nursing or in medical care, for that matter, to fix the enterprise at the same time that your unit is full of patients or that your office is full of, your waiting room is full of people waiting to see you in your office. The other input we had was a facilitator whose job it was to work with the nursing units over time to help them implement this quality improvement system. This implementation was borrowed from the primary care world that I work in, where a group has been using this model for about 10 or 15 years to work on changing primary care delivery. The facilitator's role was very important here because it turned out that there was very little time and organization, especially at the hospital where we started out to do this work. Really, the facilitator was the motor, the machinery behind getting people together for meetings, working on the directors, working on the staff nurses to stress the importance of what was going on, to help structure the work, and to help do some skills building with the team. Now, the outputs, the first thing we thought, well, if this is going to work at all in the way we think, we have to actually have evidence that they're identifying these small troubles and the workarounds and acting on them. So that's where I'm going to start. We did this with pocket cards, which were little pink cards that nurses carried around in their pocket for a shift. And after some pilot work, we put together a list of the most common categories that they identified. And what they would do is just make a little tick mark every time a problem came up during the shift. And if it came up 5 times, they would make 5 tick marks. There was a place for free text if they wanted to elaborate on something for us. And so we did this in 2 rounds at Hospital A and 1 round at Hospital B. We had about 137 nurses. The first round identified 794 small problems. The second round, which was just this summer at Hospital A, 178 staff identified 1,000 problems. So actually going up in the numbers we took as a good sign because we found that The nurses and the other staff seemed to find it useful to go through this exercise the first time, and we took it as a sign of adoption, but not the fact that they were seeing more and more small problems. So more nurses participated, and they identified more problems. So that works out to about 6 problems per 12-hour shift or so. It's not an inconsequential number. It turns out to be about half the number that Anita Tucker discovered in her research when she followed nurses around. So we have 2 hypotheses. One is that it's work to take the card out of your pocket and make a tick mark, and so maybe that accounts for the halving of the rate. The other hypothesis is if you have a Harvard Business School professor following you around all day saying, you know, you're doing a workaround right now. You've done it so many times that you don't even realize it. But there, you know, that's not probably the way that this work was intended to be done. You might also identify more workarounds. So we're going to, one theory for further research is to actually do a direct comparison between direct observation and the cards. At Hospital B, which actually is a hospital that's magnet, is much further along in its quality journey. The small problem rate was quite a bit lower. It was 3.6 as opposed to 6 per shift. This hospital participated in TCAB, and there's just been a lot more kind of frontline energy and management energy around improving the nursing work. Okay, so what the units did was, after identifying all these problems, our study team collected them. We synthesized them on some voting boards that then would go back to the units, and the nurses themselves would vote on which problems seemed to be a combination of the most prevalent, the most pressing, and maybe the most doable as a place to start. And then they formed an improvement team around that. It took usually about 3 or 4 sessions with our facilitator for the nurses to identify a problem, to select 4 or 5 people who might form the initial improvement team and take that on as their project. It took quite a bit longer for this to happen. Again, at this hospital, there was very little quality improvement infrastructure. The channels of communication to the nurses, as I'll talk about in the lessons, were actually much less prevalent than we expected, and that a naive person would expect. We weren't completely naive, but the communication difficulties were actually quite profound at this institution. Once the improvement team formed, generally the 3 teams at the 3 intervention units, they've met 6 to 9 times on a particular project that on 3 different projects that they selected, and I'll tell you what they are in a minute. So that was the kind of the process output that we were looking for, were these improvement team meetings that were happening regularly on the unit. And it is, obviously any of you who have worked in hospitals know that it's quite a challenge to carve out time for this on top of a busy staff meeting schedule that's already packed with other agenda, and not to mention the nature of the work itself. The next thing that we were looking for was that the nurses during these times would reflect on their work and develop some change strategies. One unit, this is the dirty utility room at one unit. You see stacked commodes and chairs, and it turned out that working in that dirty utility room was like every day, every hour, a game of Tetris. You had to take stuff out, move it around so you could fit something into the 2 cubic feet of space that was still available, and so that's what they chose to take on. They were wasting enormous amounts of time in this dirty utility room. You can see it's a camera phone picture, so it's not great, but if you can't see in the back, those are food trays stacked on top of commodes, and 2 spheres of life that we hope usually wouldn't mix to that extent. Here's another view. It's looking a little better today, but still, stuff is packed in there to the rafters. The red sign at the upper right says, "Please remember to wash your hands," and there's kind of a commode sitting on top of the utility sink. So you can imagine what it's like to work in an environment like that. One of the things the facilitator did was offer, ideas for improvement strategies, PDSA, spaghetti diagrams, all kinds of things to groups that actually had very little experience using them. So just as an example, the nurses sat down one day and kind of drew a spaghetti diagram about what it takes to put something away in the dirty utility room. Now, they already knew this, but the beauty of this and the beauty of the pocket cards is that it becomes a strategy to bubble up all these frontline problems that are often invisible to the leadership or else don't align with the current leadership priorities, to show them what the frontline is dealing with every day, and as a way to get extra help and resources.